make accurate diagnosis, and avoid very common pitfalls in the diagnosis. For example, you see a patient with a sudden bad headache in the emergency department, you get consulted, do the imaging, everything is fine. I can't tell you how often such patients, sudden bad, very intense headache with onset to peak within about a minute. A lot of these patients get misdiagnosed as migraine and get treated with Imitrex or sumatriptan. This is a very common occurrence. Or they get put on glucocorticoids, the old steroid dose pack, with the misconception that the sudden bad headache, because everything is negative, must be migraine. So be careful of such pitfalls, and I hope that during the next 45 minutes or so, you will go away feeling that you've really understood how to recognize this syndrome, how to distinguish it from mimics, and manage it appropriately. Okay. With that, I'll share my screen and get started. Okay, so RCVS and mimics. Amongst my disclosures, the only ones that are relevant is that Dr. Levine asked me to write a chapter in MedLink, and then Dr. Kasner in Up to Date. So those are the contributions. But then look at this one, medical legal expert witness. I think Steve knows there have been a few cases, maybe a handful over the past 20 years that I've participated in, because of the misdiagnosis, or I think mostly because they thought it was vasculitis, which is an inflammatory arteriopathy of the head of the brain, then the patient truly had RCVS. So I think that's a common conundrum. And then postpartum cases, okay, that's a very common reason for the medical legal. So I want you all to be aware that there could be serious medical legal consequences. So understand the history and evolution. Right off the bat, I can tell you RCVS is not a new syndrome. It's a new name for a syndrome that's been described by others under various different nosologies. So my contribution perhaps is just to bring everything together. To put this RCVS into context, now we're vascular neurologists, we see patients, and there's this common notion that atrial fibrillation is the most common cause of stroke. However, if you think more globally around the world, if you put together the intracranial and extracranial atherosclerosis, large vessel athero, and then the small vessel disease, these are really arteries. And then you add in dissection and RCVS, and vasculitis, and moya. In the big picture, I think arterial causes of stroke are probably the most common cause of stroke. Now, if you dissect them out, at least in the young adults, you can classify them in various ways, infectious, non-infectious, whatever. Or you can look at the angiogram and say, is the angiogram abnormal or normal? So if the angiogram shows abnormalities, you're dealing with a medium or a slightly less than medium-sized arteriopathy. And amongst those, RCVS, in my personal experience, I don't have data to back this up, stands out as number 3. So dissections, of course, account for 15% of stroke in the young. And I see RCVS at Mass General. These are not referrals to me as someone who's contributed, just de novo. It's the third most common. And I would posit that it's more common than a new diagnosis of, say, Parkinson's or multiple sclerosis amongst inpatients or amongst ED patients. So dispel the notion that you're never going to see a case. They're all around you. You just need to pick them up. Small vessel diseases are listed down below. Now, at Mass General, since I became interested as a senior resident, my first case was at that point, over the past 2 decades, I have seen one new inpatient approximately every 3 weeks. In my clinic, I'll be surprised if a clinic session goes by without a new RCVS case. Those are referrals. I wouldn't count them. Let's get to the point. What is RCVS? The next 4 slides or 5 slides are going to be very important. This was case number 3 at Mass General, a young man who came in with a postcoital thunderclap headache, no pain to extreme pain. And when I say extreme, I mean We say 10 by 10, but patients say it's 20 by 10. It's that extreme. Okay. Postcoital came in, and everyone thought this was a ruptured brain aneurysm, but no evidence of that on CT, CTA, or lumbar puncture. However, the CT angiography study showed this very smooth tapered narrowing, as you can appreciate, in branches of the middle cerebral artery in the mostly M2s. Look at this. It's a sausage on a string. Right? That's the appearance. The mid-basilar, a very common site of affliction. The superior cerebellar arteries, almost all cases that I've seen have some irregularity of the superior cerebellar artery. So that was the conundrum. Patient doesn't have subarachnoid. What are we looking at? We don't know, so we don't do much. We don't start empiric treatment. Patient did have recurrent thunderclap headaches. Every time he walked or went to the bathroom, tried to climb stairs, he'd come back with another headache. And after 3 or 4 days, he said, I'm not seeing too well. My vision's all blurry and I really can't make out what I'm seeing. So a careful neurological exam revealed the triad of Billint syndrome. If you think about Billint syndrome, you get it from AFib, top of the basilar bilateral posterior circulation strokes. But the most common scenario where I have seen it is RCVS. Why? Because the MCA and the PCA are both segmentally narrowed. So the watershed is right at the parieto-occipital junction. So that's where you get that's the root of Billint syndrome. So that's a frequent finding. And sure enough, on scans, we confirmed that he had these watershed symmetric infarcts. And you can see that diffusion, ADC, and flare. Simple observation continued, bed rest, and his deficits got better, vision improved. About 3 weeks, his TCD flow velocities, which were initially very high, about 200, 250, 300, they naturally came down. The MRA reversed. And I followed him in the clinic. He's never had another spell. That's it. This is the prototype case. Okay. Do nothing, watch, patients will get better, they'll go home, never to return. Dr. Bean? That was an infarct. So the infarct remained, but his vision improved. So he makes the good point. I'm calling this reversible, which means most patients show evidence of reversibility. You can have a few patients with prolonged deficits or irreversible deficits, but by and large, this is reversible. Lou Kaplan got into the same mix in the NEJM, and if you see the letters after the original paper of the reversible posterior encephalopathy syndrome, there are a lot of papers. Oh, we've seen this, but we've seen patients pass away from it. So he made the point, sure, you can, but 95% get better. So it's reversibility that he's emphasizing. So we went along the same line of thinking. When I started getting into this, and this is a lesson for the residents, I won't name them. They're all very prominent, probably the most prominent vascular neurologists and neurosurgeons that you might hear of. One of them said this is intracranial vasculitis. The second said, no, this patient is young. This must be a premature athero. The third fellow said, oh, this is actually a small ruptured aneurysm. We're just not seeing the blood. Even the LP is negative, but that's what's causing the arterial narrowings. And there were many other hypotheses. Now, simple logic said that, look, if 5 great minds are giving me 5 different answers, none of them really know the truth. So I went down to Conway Library and I started my hunt. I was researching thunderclap headache, arteriopathy, vasculitis, and I came across a whole array of literature with very diverse opinions. But when I looked at the mainly case reports, when I looked at the case descriptions, they were identical. Bad headache, arterial problems, nothing bad on pathology, and the patients who were reportedly better, they were better, and the folks who passed away didn't have any inflammation in the brain arteries. It happened after delivery. So I started looking at this in more detail, and I realized very quickly that between the 1960s, which is as far back as PubMed would allow me to go, the 2000s, the same clinical imaging syndrome, okay, I'm calling it syndrome. It may be 8 different diseases, but when you look at the patient, it's the same. In the postpartum setting, patients with eclampsia, patients who've abused drugs such as cocaine or LSD or whatever, it's called drug-induced angiitis. Now, at my own hospital, the great C. Miller Fisher had recognized this way back in 1971. The proceedings of the Salpêtrière Conference, which I chanced upon, describe a patient with postpartum bad headache who has this phenomenon. And he kept at it, and in about 1988, with Marie Fleming, Greg Call, and others, he put together a seminal paper in the journal Stroke, called, and henceforth in the field of neurology, vascular neurology, we thought it was a rare, never going to see it type syndrome called Call syndrome or called Fleming syndrome. In the headache literature, the same condition was described as thunderclap headache with reversible vasospasm. So the point being, very different nosologies for pretty much the same thing. So I got together with Glenn Calabrese at Cleveland Clinic, who had described this phenomenon as a benign angiitis, saying that it's really an inflammatory angiopathy, but it's so mild that everything gets better. You don't really need steroids. But he then came to appreciate that this was a vasoconstrictive phenomenon, not an inflammatory phenomenon. So we got together, started thinking about it. My first paper was in 2002. So today, 21 years later, I say RCVS has come of age, and I'm here to educate you. So I just a brief, I would say, acknowledgement of Dr. Fisher's contributions to the field. He's been my inspiration ever since I've met him for the first time. You know, when he came onto the scene, it's a bit like RCVS. You ask different people, they don't really know what stroke was all about. Everyone came to the conclusion stroke is because of some vasospasm of the artery. They didn't really know what they were talking about. Since the Hippocratic times, this went on. Think about it. Fisher at Mass General harvested brains, arteries, did pathological sections, and showed that stroke was a pathological problem with the arteries or the heart, atrial fibrillation and stroke. But ironically, it was he who put together the Call Fleming paper article, right? So he bought vasoconstriction, maybe, I don't know what vasospasm is, but narrowed arteries on simple observation. He bought that back as well as a syndrome. So it's quite ironic, I think. And he told me the bedside can be a laboratory. He's written about it, I think, in the Fisher's Rules paper, very amazing paper by Lou Kaplan in Archives of Neurology. The bedside can be a laboratory. Study the patient, go into the depths. And when I came up with my crazy ideas about RCVS, he just told me, you've got 3 cases, keep collecting cases, stick with it, maybe you're onto something. And today, I have 300 plus cases in my data set, and I think we've tried to analyze them and make sense of it. So this is a lesson for the residents here. Be inspired by the patients in front of you, try and help them. So what is it in summary? It's a group of conditions characterized by segmental constriction and dilatation. It's not commonly acknowledged that after that area of smooth narrowing, the arteries are even broader than their usual caliber. Okay, so that's that. Predominantly affects women. The mean age is 42 years in many cohort studies. Now, I'm going to show you mainly data that I'm most familiar with. Just be aware that the Mayo Clinic, Cleveland Clinic, the French group, there's a Taiwanese group, there's a Korean group, so many, and the Canadian group. So many folks are working on it, but the big picture story is identical across. In fact, the mean age is either 42 or 43, around that. The age range is approximately the same in all cohorts, okay? Almost all patients have recurrent thunderclap headaches. The word recurrent is important. The word thunderclap is critical, 90%. So the question is, what about the other 10%? Well, I think that includes patients who have an arteriopathy that spontaneously reverses, and we don't know what to make of it, but it's being clubbed in currently as RCVS. And other patients may come in, let's say, with a bleed. They may not have recall of thunderclap. They may say, oh, maybe they're stuporous and can't describe a history. So that accounts for the remaining 10%. This description of the imaging is critical. The initial imaging, CT or MRI, in a patient with a sudden bad headache is most often normal, 70% of the time. If you keep imaging them, if the patient's admitted, about 35 to 40% go on to have abnormalities. And those changes could be convexity subarachnoid hemorrhage, lobar hemorrhage, symmetric watershed type infarcts, like I showed you, or brain edema on flare, which for all in the world looks like PRESS. So we think PRESS and RCVS are overlapping entities. Now, this pattern of the first scan being normal and the second scan, when you repeat it for a second thunderclap headache, becoming abnormal, that normal to abnormal conversion is very important. I don't think any other entity that I've seen does that so quickly. In like 2 days, you come into the normal scan, and all of a sudden you've got a bleed or convexity subarachnoid. I mean, that's RCVS. I haven't seen any other entity. Most patients, everything gets better, go home to disappear, and they rarely, if ever, seek your attention again. Benign, self-limited condition. 2% can pass away, and I'll show you why I think that's been recorded, and about 5% can be left with deficits, okay? Now, there's no strong correlation between headache resolution and angiographic resolution. In fact, headache, I think, personally, starts first, and the angiogram is normal. And the angiogram becomes abnormal, headaches get better, and the angiographic changes can be prolonged. It's quite interesting. I haven't figured out why that would be, the dissociation. So as I said, 1 every 3 weeks, but thankfully it's come of age. We now have an ICD-10 code. There are national database type studies being done. Personally, I think we're just learning about this diagnostic code. So the database studies are undercalling the frequency at 3 per million or 0.02 cases per 100,000 US inpatients. What they're also not accounting for is thunderclap headache alone, which, as I'll show you, is part of the spectrum of RCVS. If you start counting all of that, you will see a lot more cases than what's on this slide. In fact, speaking to my emergency department colleagues, headache, as you all know, is one of the most frequent diagnoses, neurological diagnoses in the ED. And thunderclap headache accounts for, I would say, 30 to 40% of these, or maybe less, maybe 25% of these ED encounters for headache. So it's not uncommon. Across all cohort studies, women are much more commonly affected. And the mean age is this, but children can be affected. I've seen a boy of 6 years of age. I can keep convincing you, but I'll show you the data. This is an unfortunate young woman who passed away from complications of RCVS. I'll show you more about her case later. But we had the misfortune of taking her down to the morgue, harvesting. I harvested the renal arteries, the aorta, every brain artery. We studied it carefully. No evidence of inflammation. What we did see, however, this is the internal elastic lamina. And my neuropathologists, who are very senior, Tessa Hedby White, she said this has an unusually pleated appearance, suggesting that something is making the artery narrow. Take it for, this is the image. Now, what causes this? Before you look at all the fine print over here, which maybe you can't even read, I'll just say we don't know, okay? We don't know. What's happening here, and I'm equally guilty of this, you see a patient and you get excited, you say, hey, what meds did you take? What foods did you take? And you put something together, what unusual activities did you do? And we say, oh, that's the correlation. So here's what's reported in the literature. You can classify them as, pregnancy, yeah, because you see this in about, you see this postpartum, okay? Getting it before delivery is unusual. You typically get it in the first couple of weeks after delivery, up to maybe 6 weeks. It's the same time span as postpartum preeclampsia. Headache disorders, because people attribute this bad sudden headache to the prior history of migraine, not understanding that 25% of the world's population has migraine. That doesn't mean migraine has anything to do with this sudden bad headache, but maybe. Then there have been very convincing cases with sudden grief. So in fact, I think Fisher wrote a paper called Crash Migraine, where he describes this elderly woman whose horse passed away. And she was on the field watching the horse being taken to the glue factory, and she was very upset, and she got the sudden bad headache with angiographic changes. So I think grief is important. And I'll just, as an aside, mention that we lost a very good friend, Marty Samuels, Dr. Professor Martin Samuels. And he talks about grief and how it can affect the brain and heart. So I think there's a heart and brain connection, and I'll touch upon that in a minute. I've been guilty of implicating serotonergic drugs. Why? Because in my cohort studies, I've seen a 40% exposure rate to serotonergic drugs, not just sumatriptan, not just SSRIs, SNRIs, but a whole spectrum of them. And I've proposed that maybe it's the drugs that are doing it. But epidemiologically, there is no evidence that these drugs are unsafe. In fact, when I see patients on some drugs, I might pause further exposure for a few days. But if patients clinically need it, I resume the SSRI, resume everything later on, because you don't have a leg to stand on to say this was the drug, or you can never take that drug again. Okay. I think a lot of these chemotherapeutic agents, hormonal exposures, RBC transfusions, you start the transfusion, you get a thunderclap headache. It's been reported. If you step back and look at all of these, there must be some common underpinning, right? Maybe. And what stands out for me is the serotonergic, perhaps sympathomimetic overdrive, and a lot of these underpinnings. We saw Lee Schwalm and we were talking about Lee Schwalm, we saw a patient kept denying everything. Next day, Lee went in and he saw this big box, and she was chomping away. And like, what is that? Licorice. Licorice. How much do you have? I have about half the box every day. So, they don't recognize, but then licorice has some serotonergic underpinnings. So it's a very bright student wrote it up with us. So now licorice has made its way up here, but we don't really know. And then I'll talk about some of these other associations. As a reviewer, I came across case series of COVID-19 infection with RCVS, and more recently, vaccination with RCVS. And initially, I dispelled it as one of these loose associations. But more recently, there have been so many, I think there may be some credence to it, and it could be something to do with the ACE2 receptor, which I think may modulate the arterial tone. So it's possible that COVID in some way affects it. If you look at the subgroups, there's not much of a difference. If you cut them by drugs, postpartum or other, I think clinically they all seem the same. The lab values, etc., seem the same. The age, of course, in pregnant women is lower. Gender, well, men seem to be younger as compared to non-pregnant women. And curiously enough, they have a much higher rate of this post-coital onset, like that case I showed you earlier, as compared to women. And of course, there are other differences, prior depression, prior migraine, which of course is more common anyway in women. We're seeing that as well. But otherwise, there's not that many other differences. The outcomes and everything else are pretty comparable. Is there a role for serotonin? I personally think yes. Why? Because of the high frequency, higher than a negative control population of things like migraine and depression, which have serotonergic underpinnings. Sympathomimetic triggers are less frequent than serotonergic exposures if you look through the laundry list of these. If you look at cocaine, and Dr. Levine here is, I think, the world authority on cocaine stroke. Would you agree that you've described the carotid bulb, but if you look at the vasoconstriction, it's top of the carotid and proximal MCA. Isn't that M1? M1, yeah. But RCVS is M23, A23. So it's slightly different. And so maybe this is the difference between serotonergic and sympathomimetic. Go up to the intensive care unit, you find patients on sympathomimetic drug infusions, but they're not getting bad headache. Inject serotonin, not really. And you'll probably lose the arm because it's so potently vasoconstrictor. So it's much more potent. Examination of these patients invariably shows 3+ knee jerks, just like you get in eclampsia, 3+. Just like you get in serotonin syndrome. They have a little bit of tremor. It's not published, it's not recognized, but I've seen it. And a bit of confusion. And then if you go down to the basic science and look at the 5-HT1, 2, 3, up to 7, all these, what do they do in different capillary beds, arterial beds? think you'll appreciate that more distally, there's a role for vasodilation, which may explain the edema, maybe the subarachnoid hemorrhage, and more proximally, it's more vasoconstrictive. So I think fundamentally, I do believe that it's serotonin, but if maybe I'm wrong, whoever comes up, hopefully it's one of you listening today, you'll come up with a hypothesis. If you do, I want answers to all these questions. Okay. Why do you have recurrent thunderclap headaches over a span of, let's say, a week or 10 days? Why? How about the imaging features? Why do you develop infarcts, late brain hemorrhages a bit earlier, convexities? Subarachnoid hemorrhage is the first thing. Why? Why does it progress from distal, the arteriopathy, from distal to proximal arteries? I've done serial imaging. The angiogram is so dynamic, it's unbelievable. One segment is affected today, you repeat the CTA tomorrow, a different segment is affected, the first segment is normal. But if you look at most patients, it starts distally and then progresses more centrally. Why? Very curious. This is by and large, I've seen patients with extracranial, but by and large, an intracranial arteriopathy, restricted to the brain arteries. It doesn't affect retinal arteries. I've done fluorescein angiograms and things. Looked at, the mesenteric arteries. Rarely, if ever, are they affected. I don't know. So it's clearly an intracranial thing. Why is the arteriopathy so prolonged but yet reversible? So whatever hypothesis you come up with has to explain all of this. And right now, I think this is unknown, in my opinion. This is what I think is happening. Look at the artery and the innervation of the artery. There are perivascular nerves. And I think they supply the smooth muscles, and maybe there's some contribution from the endothelium as well. So when I spoke to David Dodick, who's a guru in migraine, in the field of migraine, and Len Calabrese and others, we agreed upon this as a hypothesis. Maybe it's the raphe nuclei in the brainstem, which are implicated for migraine as well, that contribute in some way to thunderclap headache. And there are these nerve endings that land up on the medium-sized and small-sized arteries of the brain, which is what explains the intracranial only involvement. So it's these vascular pathways of the nerves, trigeminal and serotonergic trigeminal-vascular pathways and serotonergic pathways, which must be releasing serotonin or some sympathomimetic agent and then contributing to the arterial narrowing. But why it's distal to proximal, I don't know. But if you think about a heightened serotonergic tone, then maybe the headache, hyperreflexia, the segmental nature, because the perivascular nerves are segmental, that could be possible. Endothelial dysfunction is quite likely as well. The Taiwanese and the Korean groups have published on this. And we, in this one case who went to autopsy, we also took blood samples. There was an altered ratio of sFlt1 to endoglin in that single patient. And these molecules have also been implicated in eclampsia. So I think that may be some. I think one paper, which I wasn't too crazy about it because it had some methodological shortcomings, implicated serotonergic transporter polymorphisms. That's yet to be validated. And of course, we still can't rule out some transient immune phenomenon that's causing all of this. So this is the lay of the land today. Let's see where your research leads me in the future. If you're interested, I've listed a few papers which talk more about pathophysiology, that it's vasoconstrictive, I'm convinced, based upon a vasomotor reactivity transcranial Doppler study that I did, showing that the breath hold index is not just reduced, but it's even reversed in the acute phase of RCVS, and then it normalizes later. So that's pretty convincing to me. Nowadays, we're seeing more and more associations. So RCVS is not just this brain-only disorder. We're seeing, I told you about PRESS, we are seeing extracranial arterial dissection. This is because of the dynamic nature of the arteriopathy, the extreme pain with associated extreme hypertension. Maybe it's the drugs, I don't know, but or maybe it's the arterial wall itself that's prone to dissection. Transient global amnesia, it's another one of those bedside observations, right? You see a case, you'll never forget TGA, right? It's the same. I don't know. Who am I? What am I doing here? That's usually what they say. And the imaging shows nothing, and you rule out everything. You say you had TGA with alacrity because you're so confident of reversal. Some of these patients, however, have proven to have segmental narrowing of the PCAs. So the question is TGA, at least in some patients, RCVS, predominantly posterior circulation with impaired blood supply to the hippocampal regions, causing the short-term memory loss? Maybe. Takotsubo, I mentioned the sudden grief. There's a connection, and we've seen patients with both intracranial and Takotsubo. In fact, cardiac echoes often show anterior wall akinesis, hypokinesis, which reverses. They may not have full-blown Takotsubo, but they have echocardiographic dysfunctions. So this is quite interesting. Start thinking more broadly about pathophysiology and the associations. Okay. And I did a small retrospective study. We had patients with RCVS at that time, about a decade ago, and I took vasculitis, biopsy-proven vasculitis cases as positive controls, and patients who had CTAs for TIA or some other reason, consecutive cases, as my negative control. So we had CTAs on all three, and we looked at our angiograms, and we looked at the frequency of not the vasoconstrictive, but what else do we see on the angiogram, right? So we saw unruptured aneurysms, dissections, cavernous malformations. And interestingly enough, the frequency appeared much higher in RCVS than everything else. So my point being, well, why are we seeing a higher frequency? Is it possible that HNE, the artery looks normal, but there's still something ultrastructural that lowers the threshold for patients to develop RCVS and also these other abnormalities? It's a very loose, unsubstantiated hypothesis, but I'm just telling you what some of the work I've done. So moving on, how do you diagnose it and how do you distinguish it? Now, I'm going to move from the bedside to imaging to angiogram. So that's this order. That's the natural order of seeing a patient, right? When you listen to the story, you got to be careful of other causes, ominous, deadly causes of thunderclap headache, the most important one being an aneurysmal rupture. How do you distinguish it? Secondly, as I mentioned, migraine. Well, then you move on to imaging and angiography, then other things like primary angiitis of the CNS comes up. So the recognition is bedside, okay? Almost all patients will complain of the sudden worst ever headache. There are different situations in which this headache could start, one being sexual activity, the other being exertion, the other being maybe cough. And in the International Classification of Headache Disorder, these are classified as benign sexual headache, benign cough headache, benign exertional headache. Really, this is all thunderclap headache. At least that's the way I view it. And I think this is a spectrum. And the Taiwanese group have shown that this patients with isolated thunderclap headache, if you image them, about 40% will have MRA abnormalities consistent with RCVS. So that's the overlap. And the character of the headache was no different in the study published in Neurology by Chen et al. So if you hear a story, today for me it's a telephone diagnosis. Someone calls me and said, I had a bad headache, went to the ED, CT was negative, I had a bad headache again, and today it's come back for the third time. I'm in a total mess. Put the phone down. This is RCVS. Don't go back. You'll be fine. Just take some bed rest. That's the advice. There is no differential diagnosis in a patient with 3 or more bad sudden onset headaches within a few days. There's no differential diagnosis. That is not a ruptured aneurysm. If you look at the literature of sentinel bleeds, where patients come in with a bad headache, and then they have the second bad headache or whatever, and they have this aneurysmal bleed. The first bleed is typically because of the rupture, and the second bad headache is because of a rebleed. I've looked 20 years, I've asked very senior colleagues, they have not seen any other condition with 3 or more thunderclap headaches other than RCVS. And Andy Cross's paper, the average RCVS headaches is 4, the maximum was 28. You can imagine. And as I said, recall bias may explain the minority without. Blood pressure is typically labile up front because of the bouts of pain or whatever else is going on. Berlin syndrome common, visual scotoma is very ill-defined. Patients can't describe their vision, understand that. You know, when the resident presents, it's one story. When the attending comes in, it's the other story. That's because they've had time to think and integrate their thoughts. So we have the advantage. But also, it's very difficult to really define what you're not seeing. So hyperreflexia, and then in hospitalized patients, these are the complications. You can get stroke or press in a large amount of patients. And you can be left with hemiparesis, visual deficits. And initially, there's encephalopathy. Initially, there could even be seizures, about 17% in my cohort. Generalized tonic-clonic at the onset in patients who concurrently have press. Okay. John Edlow has published this. This is the algorithm and the differential diagnosis of the first thunderclap headache. First thunderclap headache. What you don't want to do in a patient with the first presentation of a thunderclap headache is miss any of these. So you need to do an urgent, and I mean a stat CT scan. You don't want to miss subarachnoid hemorrhage, lobar hemorrhage. Consider a CT venogram for venous sinus thrombosis. You should do a CT angiogram for things like dissection or RCVS, right? What happens? So you do a brain scan, it's diagnostic, you're working. It's non-diagnostic, it's normal. Then I instructed them, and he agreed, that you should try and tease apart, does the patient have multiple thunderclap headaches? If that's the case, do the CTA and diagnose RCVS, straightforward. But if you have one bad headache and the CT is negative and the scan is beyond 6 hours. Within 6 hours, CT has 98% specificity and sensitivity, I think, for picking up leads. But beyond that, you should do an LP. Okay. So this is a great algorithm. I've worked with them to develop it. I truly believe it, and I think you should download the paper and incorporate this as part of your workings. So then I think this group, Korean group, has come up with the RCVS thunderclap headache score in an effort to say patients who come in with a thunderclap headache, how do you know it's RCVS versus something else? The score is pretty good. These are the main variables identified to make the model: pattern of thunderclap headaches, the sex, the triggering factor, whether you identify one, and the blood pressure surge. You total it up, you get a score, range of 0 to 12, and 7 being the cutoff. I think above that, you have pretty good specificity and sensitivity. So I think the score is great, with one shortcoming, that when they developed the score, patients with aneurysms were excluded. I'm like, well, that's the main thing I want to exclude when I use a score. But if you don't use that to compute the score, then that's a problem. And they also included patients with isolated thunderclap headache without RCVS in their analysis. So I think those are the shortcomings. Otherwise, the score is pretty good. So that's the bedside sort of thunderclap headache. Then you move on to additional imaging, right? Now, with primary angiitis, the problem is that when it was first described in the 50s, the world caught on that this is like a progressive fatal condition. You need to give steroids ASAP. That was the bottom line. But what they didn't know is that there's this other condition, RCVS, which can mimic. Why? Because headache is common, strokes are common, and angiographic abnormalities are common to both conditions. But what we didn't know about RCVS then, so not we as in our predecessors, so they started taking shortcuts. They started diagnosing vasculitis in the absence of a brain biopsy or even a lumbar puncture, just on the basis of headache, angiogram, abnormal, must be vasculitis. And they blasted the patients with glucocorticoids. Now that, I think, has been a mistake for more than 60 years, and it's still going on, believe it or not. It's still going on even at Mass General. So I'm befuddled, trying my best, and I need your help to educate folks. So we don't want to send RCVS patients to a brain biopsy or give them a lifetime of glucocorticoids or immune suppressants, right? You don't want that, and that's a huge problem. So this is a nice paper, but I think it was published in Archives of Neurology by David Hellman or someone. RCVS versus PSCNS. The devil's in the details. The character of headache is very different. The infarct pattern is different, as I'll show you. And hemorrhages are common in RCVS, but at onset in vasculitis, I think for vasculitis to present with a headache, quite rare. I haven't seen one. By the way, even the angiogram is different. Okay, in vasculitis, you get this rather irregular notched appearance, and vasculitis predominantly affects the very tiny arteries, which are invisible on angiography. But in the patients with angiographic changes, it's quite irregular and notched because it's inflammatory. Okay. These are the infarct patterns. We published this in the Annals of Neurology. Most patients, normal scans, but in the sulcal spaces deep within, that's where the arteries run, you may see flare hyperintensities because there's dilated vessel with slow flow within them. These are not clots. These are just, you see the same pattern in luxury perfusion or whatever. You might see this. Watershed infarcts, because it's usually a symmetric arteriopathy, and then changes of press, this convexity subarachnoid hemorrhage. By the way, when brain aneurysms rupture, it's in the Sylvian fissure and basal cisterns. They don't rupture up top over there. So this convexity hemorrhage is not a ruptured brain aneurysm. Rarely it could be a mycotic aneurysm, but that's a rare entity to begin with, right? And then you can get lesion combinations. I think Steve was telling me patient with infarct and brain hemorrhage at the same time. By the way, very few conditions cause infarcts and hemorrhages at the same time. RCVS is one of them. Vasculitis, not commonly known, but in the Mayo Clinic series of more than 170 patients, I think not a single patient came in with a normal brain MRI. When vasculitis comes to clinical attention, MRI is abnormal. What do you find? You find little infarcts, which are in the deep, the small arteries deep in the brain, or you find T2 changes or some leptomeningeal enhancement, sometimes a mass lesion. We've seen this. This patient was biopsied, thinking it's a GBM, proved to have vasculitis. And then sometimes you get these medium-sized arteries with territorial infarct. So this is vasculitis, very different pattern, right? So the devil's in the details. And I compared the angiographic changes. This is a cartoon showing it's much more symmetric, right? And it's M2s and A2s involvement in RCVS. In vasculitis, the changes are less prominent and they're a little more asymmetric, okay? Just as a brief mention, I've seen like 5 patients exhibited in this picture where they came in with hemorrhage. They proved to have vasculitis. So we went back and took the history, and some patients were right there, so we took the history. Uniformly exposed to high amounts of sympathomimetics. One patient was injecting Afrin into his nostril. The other had taken diet pills, overdose of diet pills. So in thinking about it, I personally think they probably had vasoconstriction, and then it was so intense and prolonged that just like vasospasm and subarachnoid hemorrhage, you can get a secondary inflammation, and that's what caused the necrotizing angeitis and rupture. So there can be an overlap between RCVS and vasculitis. I'm going to end very quickly now. So we've looked at the clinical story of headache. We teased apart the recurrences and nature of the headache. We've gone to the imaging and looked at the lesion patterns. Now let's look at an angiogram that's abnormal and the patient with appendage. So you really don't know what's going on, right? In patients with abnormal angiograms, what are the clinical features that can distinguish RCVS from some other arteriopathy? So with that in mind, we developed a scoring system. We took all patients with undifferentiated angiographic abnormalities and the final diagnosis, either imaging or pathological of one of these entities. And we looked at what predicts RCVS. And we came up with this clever acronym, clever because Eva Rocha, who's in Brazil now, very clever young woman, she coined this acronym. R for recurrent or single thunderclap headache, thunderclap. Carotid intracranial involvement, which should be absent, that's more cocaine, it's not RCVS, the top of the carotid. Vasoconstrictive trigger, so that's RCV, and then 2 S's, one is for sex and one is for convexity subarachnoid hemorrhage. So that's the RCVS2 score. The components are here. It's heavily favored by the presence of thunderclap headache. But if you get that in a patient with arteriopathy, you can be pretty sure that there's RCVS and none of the others. There was one patient with moya moya who came in with a bad headache, so the scoring is not perfect. But if you look at the sensitivity and specificity, A score on the RCVS2 score of 5 or higher, up to 10, very high specificity and sensitivity for RCVS. A score of 2 or less favors vasculitis or something else. Okay. So above 5, below 2. What about 2 to 5 or 3 and scores of 3 and 4? I think there it's a gray zone. You need to be a little more knowledgeable, look at the imaging, tease apart the story to make the diagnosis. So this is available on MD Calc. We put it up for easy reference for you. I think the score is very important because groups around the country and around the world have started taking young people. You have a thunderclap headache, come in. Do you want an angiogram? Do you want a little injection of nicardipine into one artery to diagnose RCVS? Would you rather not come to me and say, Doc, I've got 3 thunderclap headaches, my angiogram's abnormal. Do you think I have RCVS? I'm going to say, well, you don't need any intra-invasive procedure. You don't want to dislodge some clot or get some dissection or have a femoral artery ballooning up because of this groin puncture. So I think it's not without risks, right? Doing an angiogram even in young people. And with the specificity of 98, 99%, use the score. Don't use intra-arterial injections into brain arteries to make a diagnosis. And that's my point. So, and plus the score can be applied at the bedside in the ED. You don't have to wait for angiographic reversal, which was historically when we confirmed the diagnosis. This is so good that you can confirm it today. Other folks talk about advanced brain MRI. I have a lot of respect for the folks and this technique. This is the 3 Tesla vessel wall black blood imaging. Okay, this shows you details of the arterial wall, and you can see some eccentric enhancement like so, which could be seen in vasculitis, could be seen in athero. You should not be seeing it in RCVS, but I've seen this in RCVS. I have. I mean, I've seen this enhancement, and I've seen patients with RCVS with a lot of symmetric enhancement, and I've seen none in patients with biopsy-proven vasculitis. So I think to make the diagnosis, pinch of salt, okay? Don't rely too heavily. It's a good test if it supports what you're thinking already. It's a great test to follow patients, say with vasculitis, to look for response to immune therapy. So be careful of this. And again, I don't think the specificity is higher than the RCVS2, very simple bedside score. Investigations, next step. Okay, I think you don't want to lose some important, what should I say, predisposing factor. So toxicology, very high levels of serum calcium can cause vasoconstriction. In today's day and age, look for COVID, antiphospholipids, and then VMA5 HIA levels because of the rare patients with pheochromocytoma who come in with intracranial arteriopathies. And an ultrasound for this echocardiographic left LV hypokinesis. I personally avoid CSF studies if I'm confident about RCVS because I think lowering CSF pressure can precipitate a thunderclap headache. And to me, that's not a good thing. Of course, reserve additional tests, including the intra-arterial, if you're really unsure about the diagnosis. Now, the top line is critical. Less is more. Symptomatic treatment alone. Don't hold back on opioids. These are patients with the worst headache possible. So I give them bed rest. I admit them. You don't want to send a patient home with the worst pain they've ever experienced to have them get the second attack at home. Keep them in the hospital. It helps. They calm down. The bed rest helps. A dark environment helps. They need really pain management. So admit them. Try not to send them to the ICU. The ICU folks start monitoring blood pressures with A lines. They start sending the patients for angiographic studies. You don't need all of that. Avoid blood pressure modulation because hypertension can provoke vasoconstriction. And if you lower the blood pressure when brain arteries are narrow, you might jeopardize the brain with cerebral ischemia. So I don't modulate blood pressure unless it's extreme. If it crosses 180, maybe I'll give something, okay? Avoid glucocorticoids and reserve invasive procedures for the fulminant cases who are clinically declining. Angiograms, imaging, you're not treating images. Treat the patient. If they start worsening, take them up because you have nothing to lose at that stage. I'm going to spend just 30 seconds on this. This is the graph showing event curve showing non-glucocorticoid exposed patients versus glucocorticoid exposed patients who had a confirmed diagnosis of RCVS. These are events. These are clinical events where the patient had prolonged or persistent clinical deficits. I'm not talking about TIAs. I'm talking about clinically meaningful deficits after the onset of RCVS. Many more events with glucocorticoid. Then the question is, was the patient going down the tubes and we started giving steroids to prevent it? Turns out that the inverted triangles show you the time point when glucocorticoids were started and when the patient had clinical worsening. You can see all these are connected 3 to 5, maybe 7 days prior to this worsening. So my take on this is that if you, in a patient who's exposed to steroids, maybe they were going to worsen, maybe you gave steroids, but steroids did not prevent the worsening. And it is possible, based upon this temporal association, that glucocorticoids in some way, maybe because of their mineralocorticoid action, maybe something else, are contributing to the worsening. This event curve shows you clinical worsening. I'm not showing you the angiographic worsening and the imaging worsening identical. So on all three fronts, glucocorticoids didn't help. And the same has been observed in the Cleveland Clinic analysis as well. So I think you should avoid steroids in patients with RCVS. Intraarterial vasodilator is not as a diagnostic test, but in the rare case who's really succumbing, I think it's worth trying it to the salvage procedure. In closing, this is what happened to that young woman, 36-year-old, delivered twins, transferred to my hospital. Very terrible CTA appearance of narrowed arteries all over. She was conscious, awake, chatting with us, had a little bit of left leg weakness the next day. The MRI showed very early signs of DWI change. So the ICU team got enthusiastic, sent her for this intraarterial dilation. They went down, injected just the left MCA, I think, with nicardipine. Every artery on the subsequent injection was open. So a little, I don't know how that happened. You inject one artery, all 10 arteries in the brain open up. It's pretty impressive. So we were all pretty happy. The patient came back and had this rebound vasoconstriction by TCD. So went back, kept going back 5 or 7 times. And regrettably, even though there was a great angiographic outcome each time, look at the change. Huh? Pretty impressive. The brain didn't fare too well because of reperfusion damage that I think we doctors probably precipitated. Maybe she was going to progress anyway, I don't know, but I think the angiographic procedures are not benign. There was hemorrhage, edema. This is the patient that succumbed. Now, this should not happen. Okay? So please be careful. So today, in my opinion, my summary, it's come of age. We can diagnose it on admission using a very simple, you don't need scores. You're all fantastic neurologists, right? So you can, now you know about RCVS, you can listen to the story and make the diagnosis. The ED physicians could use the score. And no one should really be messing around with the brain arteries to see if they dilate or not. In the acute setting, I think it's important to limit exposure to these vasoconstrictive meds, but in the long term, I think it's reasonable to restart if clinically indicated. I think empiric steroids, often given for the fear of missing out a patient with vasculitis, that approach should stop. Vasculitis is a chronic condition. If you delay steroids by 2 days, I don't think much is going to happen. Okay? Intraarterial vasodilator approaches are not needed. And today, because I'm so confident of the diagnosis and because I've seen that 98% of arteries reverse, either almost or almost completely or completely, I've stopped doing a CTA and follow-up. It's radiation, it's expense, no need. And the outcome is excellent. At the point of discharge, 95% walk out of the hospital, 95%. 2% pass away because of things that I think we do, or some natural progression. So recurrence of a full episode is exceptional. 5% can get one more bad headache later on, but so can any of us, because thunderclap headache is a primary headache disorder. And then for pregnant women, I advise them to monitor for preeclampsia in future pregnancies, because in patients with eclampsia, Cheryl Bushnell and others have shown that long-term you can get chronic hypertension and a higher risk for subsequent preeclampsia. So with that, I give them this logical advice. There are no known genetic implications, and after these reassuring words, patient feels so relieved. Many of them cry, even over Zoom when I'm seeing them, and they're like, okay, it's not going to come back. That's great. Children are fine. That's great. Send them on their way. Okay. So there's some future directions for people who want to do basic science research in the field. I haven't because, it's a benign entity. Patients are getting better. Why would I do rat models? So that's been my approach, but I've now been advised that maybe you should, because you learn something about vasospasm and aneurysmal bleeds, you learn about press. So there is some justification. So I think there are some enigmas and future directions. I mean, I think thunderclap headache comes first, but we need to prove it. Again, all the previously mentioned conundrums could be worked on, and I've listed them here. I'm just going to end by acknowledging the inspiration of Dr. Fisher and Luke Liu as well, who helped me earlier on. Cleveland Clinic, and then, of course, Eva, and then Akif Topçuoğlu in Turkey. They were the main workhorses amongst many other fellows who worked with me. It turns out my father's a neurologist, and he's sent me the 5th case I ever saw, and he's been on to this. And my mother, who passed away earlier this year, she's an OB. And she was so interested in this because she used to see postpartum women with bad headaches as well. So I acknowledge them, and this is the old family who suffered through my absence, at least in the initial years. But they're here in New York today, so thank you again, Stephen. So I'll stop here. Open to questions. I hope we're not too much over time. Yes.
Thank you for a wonderful talk. Have you ever seen spinal cord infarction from RCVS?
Great question.
Workup doesn't show anything, and is it the vertebral getting to the anterior spinal if it doesn't happen, or
I haven't seen spinal cord. That's another I haven't. Yeah, I wonder why though. Right? Maybe I haven't looked, but I haven't seen symptomatic spinal cord injury in patients with RCVS. What I have seen is sudden onset of hearing loss bilateral. And I've seen maybe 8 cases. So it seems unusual. I'll probably write it up one of these days if I can think of a connection. Okay.
You said the caliber of the blood vessels do not really correlate to the intensity of the headache.
Right.
Correct?
Right.
So what's really the role of nimodipine in some of the RCVS? Because I know that there's been papers on adding nimodipine earlier.
Yeah. So this is one of those misbeliefs, right? So we think that nimodipine helps the arterial narrowing and subarachnoid hemorrhage vasospasm. It doesn't. I think it helps the brain, but not the artery. Now we think what the vasoconstriction, now I didn't call this reversible vasospasm syndrome. I said vasoconstriction syndrome, and that's because I was advised by none other than Dr. Fisher. He said, what is spasm? I don't know. Why don't you just call it constriction, because that's what you're seeing. So we said, okay, we call it reversible vasoconstriction syndrome. Now, some docs think that this vasoconstriction is identical to vasospasm, whatever that is, and aneurysmal bleeds. And if nimodipine is being given there, then maybe we should give it here. So there have been retrospective analyses of patients with RCVS exposed to nimodipine, and there was no evidence of angiographic change with or without nimodipine. However, patients reported less headache with calcium channel blocking effects. So on that notion, I often give verapamil. It's easier, you can give a couple of doses to make sure the blood pressure doesn't sink and then go to the long acting. In the nimodipine, it's more expensive in every 4 hours. So.
Yes, if I could just, have you ever seen venous constriction in these patients?
Yeah. Maybe I didn't emphasize enough, but in that slide I showed you of the imaging overlap, about 30% of patients with RCVS have hypertensive encephalopathy type changes or press on brain imaging. Walter Bartinsky, who is the guru of press, has done analyses of MR angiographies in patients with press, 48%. So I think there's this overlap between the spectrum of headache and the spectrum of hypertensive encephalopathy, at least on basis of imaging. They both may be eventually disorders of cerebral autoregulation in some manner. Yeah. So if they come in with their first thunderclap headache, you want to get it immediately, right? You want to rule out arterial dissection or something else. If it's normal and the patient has a sudden bad headache, what do? You can either do nothing and just wait for a second bad headache, which is what I do. I don't keep imaging them if they're clinically better. If they have a couple of headaches and the patient wants to know what's going on and we want to confirm, then you can repeat a second CTA. If the patient does not have a bad second headache or a third headache, and just after the first one, you can miss RCVS because it's so distal that the CTA is normal. In those patients, if you're really interested, you can repeat the CTA in maybe 4 or 5 days. And by then, the imaging should become abnormal with the proximal arterial affection. Between CTA and MRA, maybe it's because of the flow or some other reason, I find MRA to be better. And the advantage is you can also image the parenchyma. You can look for those flare dot signs on the sulcal spaces, which are indirect markers of RCVS. So there are many advantages of getting MRI. Yes.
How long do you recommend to admit the patient with recurrent headache?
Yeah. Great question again. I don't have a solid answer for this. I'll tell you what I've generally done. Patients are in extreme pain, I don't send them home. Once the pain settles, I make them walk. I have them with the therapist walk up the stairs, do mild exertion, go to the bathroom. If they tolerate all that, I release them. With the advice that, look, we think you're okay. It's possible you'll get another bad headache. Don't hesitate to come back. If you don't tell them that, they'll never forgive you. So,
And Dr. Singhal, this is Murray Schwaka. I'm a headache specialist. I'm in
70%. 70% of no brain parenchymal imaging changes. Oh, CTA changes. Yeah, then that's the issue of, thunderclap headache with normal CTA. Is that RCVS? So this was a study conducted by the Taiwanese group. They've got a huge medical center and probably the largest cohort of RCVS today. They took patients with thunderclap headache, published in neurology that I think almost half the patients did have angiographic changes, half did not. But they compared the two groups, there was no difference in outcome, presentation, or whatever. So they concluded that thunderclap headache is part of the spectrum of RCVS. So it's really a question of semantics. We call it thunderclap headache or primary thunderclap headache. If we see angiographic changes, we change the name and call it RCVS. To the patient, it's still the same problem. Yeah.
There's one question in the chat.
As I mentioned, at least the published reports of RCVS in the rare cases that succumb and go to autopsy, I think there have just been a couple. And the others who've had temporal artery biopsies or brain biopsies, the problem is you make the diagnosis when the biopsy is negative. So with that in mind, these patients have had normal biopsies. And the patients I've seen in MGH have had normal pathology. With the exception, Nick, that exception being if you've taken a high dose of a vasoconstrictive medication or sympathomimetic, you get vasoconstriction early on and then secondary inflammation. That may be possible. But I think we've all concluded this is a vasoconstrictive phenomenon and you should not have inflammation. If you have inflammation, then you're probably into that vasculitis spectrum.
I have a question. If a patient has both breast and RCVS, what is the therapy to treat the pressure?
Yeah. Thank you for thinking about this. Clearly, if they have brain consequences of that look like press or hypertensive encephalopathy, it's probably imperative to treat the blood pressure a little more aggressively. The caveat that if you also have narrow arteries, then it's your judgment as to how low the blood pressure should come. You don't want it to go above 180 under any circumstance. But if it's with press, then maybe 140 is reasonable, I think. Yeah, magnesium is also given. I'll tell you all the drugs I've given. We've done everything, and there's no evidence that anything has worked. We've given nimodipine, verapamil, cyproheptadine, which is a serotonin antagonist. We've given dantrolene. Suzanne published that. I think there was another agent as well. So we've tried many things. Magnesium is often given on the notion of eclampsia being part of the spectrum. Personally, I think no harm. No, I mean we've done magnesium in acute stroke type studies, and we didn't find any harm. So I think there's no harm for magnesium.
Have you tried CGRP inhibitors?
No, I've not. But great thought. Maybe this is food for thought for a prospective study. Okay, well, thank you. Thank you for your great questions. Great questions.